Good morning, everybody. My name is Charlie McMahon, and today I'm going to be talking about measuring COVID-19 mRNA vaccine effectiveness. So I'm going to start off with a little bit of background research. First of all, we're looking at vaccine effectiveness, but what does that actually mean? For my project, I looked at how well our COVID vaccines were performing inside a true human living, breathing population. When we're looking at COVID vaccine effectiveness, different research teams can look at it in different ways. You can look at vaccine effectiveness as preventing infection or preventing severe hospitalization or severe illness. Severe illness was the route that my research team decided to take. It's important that we look at vaccine effectiveness because, as we've all known through the course of the pandemic, the virus itself has mutated several times. So in order to keep up with the mutating virus, we have to change our vaccines. We started off with monovalent vaccines, which were developed to target the initial alpha strain of COVID-19. And as I'm sure you're all aware, we transitioned to bivalent vaccines just a few months ago that target not only the initial alpha variant, but also the subvariants that have emerged since then. It's also important because the COVID virus itself is a new virus. So not only are we learning about the virus, but we're learning how best to study the virus. So not every research study that comes out initially is going to be perfect. There's going to be confounding factors that we might not even know exist. So we need to do as many studies as possible so that we can learn how to learn correctly about the virus. So for my Keystone project, I based a lot of the research on the work that I did at Beth Israel Deaconess Medical Center, specifically in the emergency department research team. I've been a part of the ED research team for a little over a year and a couple months now. On the research team, I was involved with the Ivy project, investigating respiratory viruses in the acutely ill. This is a large study that's being run across the United States. It's set up as a case control study. So for my responsibilities on the team, I sort of had three main jobs. One of them was to swab patients. We collected nasal swabs of both COVID positive and COVID negative patients in order to determine who our case and who our control samples would be. I was also tasked with going into the Massachusetts vaccine database to verify COVID vaccination status and which brand of vaccine our patients had received. In addition to that, I also conducted demographic interviews and medical history interviews with our patients and verified their information with their medical records in order to collect this data and send it off to the CDC. For the second half of my project, it's more reflection-based. So I did a literature review of similar studies looking at COVID vaccine effectiveness to see how different research teams across the country are analyzing this problem and how we can better understand what's going on, as well as some thoughts about the future of public health research in the United States and how to best prepare ourselves for the next pandemic. So the Ivy Network, what is the Ivy Network? The Ivy Network is a huge study, like I mentioned, that is run across the United States. We are based in 18 different states, and for the COVID project, we're based at 21 different medical centers across the US. This is really important because it allows us to have a truly representative sample of the United States. The COVID virus is not being transmitted at the same rates across the country. So the data that you collect in New England may not be representative of the data that you collect in Florida or Texas or California. So by creating this huge database and this huge network, we're able to make sure that our samples are truly representative of the US population as a whole. So the Ivy project is an ongoing project. It's been going on since the start of the pandemic, and we will open up enrollment, we'll collect patient information and biological specimen collections, and then we'll stop enrollment when we've received enough data, and we go back and we analyze the data that we have. After we analyze the data, we'll adjust our study protocols, basically to see what's going on with the virus and how, like I said, we can better understand what we need to study and how the virus is changing. So for the first paper that I contributed data to, it's called IV3. This data was collected from December of 2021 until August of 2022 during the Omicron variant. So during this time, the only vaccines that were available were the monovalent vaccines. We calculated vaccine effectiveness using the odds ratio, which is an epidemiological statistic. And the main finding from this paper was that vaccine effectiveness decreased significantly post 150 days vaccination. And across all groups, when we standardized and stratified looking at age and other demographic variables, vaccine effectiveness dropped off. So this is to say that the COVID vaccines do work initially, but that effectiveness is going to wane. So this brings us into IV4. Once we realized that the COVID vaccines were not doing as good of a job long-term as they were initially, the medical community started to transition to bivalent vaccines. Bivalent vaccines, like I said earlier, are developed to target not only the initial alpha strain, but also the mutated substrains. So the IV4 paper, this is actually a really exciting one, as it just came out a few weeks ago. This paper contains data collected from September to November of 2022, so just this past fall. The sample size is a little bit smaller because this is it's a novel investigation. We knew that the bivalent vaccines were safe, and we knew that they were effective, but we didn't know how effective they actually were in a population. If you notice, the IV4 paper looked solely at individuals in the age group 65 plus. This is because we noticed from the earlier studies that since we were measuring severe illness, most people that were coming down in the hospital with severe illness were in that age 65 demographic. Younger patients, this is not to say that younger patients aren't getting severely ill, just that the majority of cases and where the medical community needs to focus is on that 65 plus community. For this project, we looked at absolute versus relative vaccine effectiveness. Absolute vaccine effectiveness shows how well the bivalent boosters protect you from severe hospitalization as compared to receiving no COVID vaccine. Relative vaccine effectiveness shows how much more protection a bivalent vaccine is going to give you as compared to someone who's received just a monovalent vaccine. So the big takeaway from this project was that when comparing against unvaccinated and monovalent vaccinated individuals, vaccine effectiveness remained greater than 70% across all groups. So this is showing us that the bivalent vaccines are effective and do their job correctly, at least in this age 65 plus demographic. So all in all, why do we need IV, and why is this project so important? The IV project is funded and run through the Centers for Disease Control and Prevention, which is one of the main groups in the United States that sets our public health guidelines and public health standards. They're the ones responsible for determining who gets a COVID vaccine, when they're approved, how they're distributed, all that good stuff. So the data that's coming from this project is directly influencing the regulations and the guidelines that we've all become comfortable with and we've all seen in the news over the last few months and few years. In addition, data from this project contributes to things like the National COVID-19 Preparedness Plan, something that the White House put forward in a similar way to detail how we move forward, how we distribute vaccines, and how we prepare ourselves for the next pandemic. For future directions of this research, we compiled a huge database of secondary data. One of my core tasks, as I said earlier, from this project was collecting demographic and health information from all of our patients. So not only do we know things about what kind of vaccine people got, when they got it, we also collected information about previous cancer diagnoses, cardiovascular disease, other chronic conditions that may affect their outcomes with COVID. So secondary data is a really valuable tool because if you want to go write a research paper, doing full data collection is expensive and costly, takes a long time. We have a huge database with thousands and thousands of data points that are going to be very easy for future researchers to come in and build projects. So I just want to thank everybody for listening today, and I want to give a big thank you to my advisor, Dr. Sophie Godley, out in the audience today, as well as everybody on the Beth Israel Emergency Department research team for helping support my research and support my work over the last year. And also a big shout out to Alex Weingart, who's been a real mentor for me at the Emergency Department. And as well, a big thank you to Professor Preston and everybody in KHC in the KHC office.
Great job, Charlie. I'm curious about the changing sort of conceptual category of effectiveness. It sounds like one of the interesting things between the two studies across the span so far of Ivy is that you got more nuanced in your understanding of what counted as effectiveness in sort of different levels. So I'm wondering how your understanding of what counts as effectiveness has changed over the course of the study and how you see that then in terms of future iterations of this, how you identify effectiveness, whether that also has a kind of a different range of factors that counts. Is it just no infection? Is it no long COVID? What are all of the different ways that you understand effectiveness, and why does that matter?
Yeah, that's a really great question. So as I'm sure you can all remember, when the COVID vaccines were first being developed way back in the spring of 2020, the messaging that was put out by the government and by different public health institutions was that we were going to get vaccinated to stop the spread. So we thought initially that vaccination would literally stop the spread of the virus. We would stop future infections from coming. And while that was true initially, the number of viral cases took off way too fast. And that became just it wasn't possible at that point. So we started to look at, okay, if we're putting this vaccine in people, what's actually happening? And what we noticed was we're not really able, to a certain extent, we can prevent these new cases from coming up, but these vaccines are much more effective at keeping people out of the hospital, keeping people out of the ICU, keeping people off ventilators. So I think that's one of the really cool aspects of this project. We're really learning about the virus still, even to this day. We're still learning how the virus works, how we study it, how we figure it out. It's been really interesting, especially during the literature review, seeing how different teams quantified vaccine effectiveness. I found some papers, even from as late as 2021, that were measuring vaccine effectiveness as how good the vaccines were at preventing new disease, which at that point, we all, for the most part, I think realized that that wasn't one of the goals anymore. The main goal was to prevent severe illness. So it's been interesting to see how that's definitely changed. And I think this is, the concept of vaccine effectiveness is something that we're constantly going back to. Like you mentioned, long COVID, it's all sort of part of the project, part of the data analysis.
Great job, Charlie. For all the times that we've talked about this, I don't think I've ever asked you this. Did you feel like the people that you were talking to changed over the course of the time that you were doing this work? Like in the ER, did the tone or their feelings about participating or even just being there, like did you notice a shift?
Yeah, unfortunately, I think the shift was not the most positive. There were a lot of people coming in, a lot of frustration, especially later in the pandemic. People who were saying, I never got COVID in 2020. I didn't get COVID in 2021. Now it's 2022 and I got COVID and I'm in the hospital. And, I followed all the rules. I got vaccinated. What did I do wrong? And it was hard for us, especially for me, not being a medical professional. I can't give medical advice to people. So being comforting and being caring and reassuring to people without saying anything that's really going to impact their care or anything like that. So there's definitely, I would say, a lot more frustration now than there was initially. But I would say there's definitely, people are still very interested and eager to participate in the research, especially because this is so new and this affects literally everybody. So, all right, thank you, everybody.